Faculty of Health Sciences, Civil Hospital Karachi, Department of Neurology. And today's topic of lecture, which I supposed to deliver, is on chronic central nervous system infections. Okay. So before going into details of infections which is related to central nervous system and which will be responsible for chronic CNS infections, just review the basic points which we will encounter again here. As some of my colleague in last week has taken lecture on acute presentation of viral, bacterial, and certain protozoan infections, which will present as meningitis or encephalitis. He has discussed in very detail how to diagnose with the help of sign and symptoms and CSF findings, brain imaging, and later on their treatment. Also he will discuss. He has already discussed on certain brain structures which will be involved in this process. So brief review of those things. Again, as we know, central nervous system comprises of cerebral cortex and spinal cord, and this spinal cord or brain is covered by certain meninges apart from skin and skull. These meninges are called leptomeninges, and these basically from outward to inward is dura mater. This blue one is dura mater, and then arachnoid matter, and then pia mater. Just below the pia mater and arachnoid matter and pia mater, there is a space which is known as subarachnoid space, which in which there is situated vessels and vascular bundles, including veins and arteries of the cerebral system. Now, how, as we already discussed in acute type of meningitis, there are certain pathologies or pathogenesis which is involved in acute settings. There are again certain pathways which mainly are of three major pathways which exist, by which an infectious agent gain access to central nervous system. One of well-known pathway is invasion of the bloodstream, which is known as, if it is because of bacteria, it is termed as bacteremia, and if it is because of virus, it is basically known as viremia. Apart from this invasion of the bloodstream by those bacteria or viruses, there is another form of involvement of the brain, which is known as a retrograde neuronal pathway. Firstly, olfactory nerve and peripheral nerves, they are initially involved by those pathogens, and then retrogradely involvement of spinal cord and central nervous system will take place. The third pathway from which patient or pathogens may access to spinal cord or brain is direct contagious spread. For example, your patient has a history of otitis media or sinusitis or certain type of congenital malformation which will give access to those pathogens towards meninges or structures of the brain. Though indirectly they can cause meningitis by direct invasion. So according to the classification, when we say your patient has chronic meningitis or acute meningitis, if meningeal inflammation persists for more than 4 weeks along with associated CSF pleocytosis marked raise in proteins and certain cells, then it is termed as chronic meningitis. And this is basically usually caused by Mycobacterium tuberculosis, different type of fungus, and protozoal parasites. We will discuss in detail CNS tuberculosis and their different type of presentations, and also fungal infections. So the underlying causes of acute and chronic meningitis differ. That's why we have certain different plans for chronic meningitis as compared to acute meningitis. So according to causes, community-acquired bacteria and viruses are the most common causes in acute meningitis, while certain type of atypical bacteria, different slow viruses, and certain type of fungus. And apart from all these infective causes, there are non-infectious etiologies which are directly or indirectly involved in cases of chronic meningitis. So, considering potential causes of chronic meningitis, we have a long list, and I will just introduce here certain classifications, so you will know these are different pathogens or different type of causes of chronic meningitis. So if your brain doesn't know, your eye doesn't see, so you should know certain rare causes as well as certain different type of bacterial, spirochetal, viral, and non-infectious causes of chronic meningitis. So in infectious causes, Mycobacterium tuberculosis is the most commonest cause, and again certain spirochetal infections, and like leptospira, and bacterial infections include Listeria monocytogenes, Nocardia, and Brucella. Viral, last but not the least, is HIV infections are very prone to have or manifest as chronic meningoencephalitis. Certain fungal infections including Cryptococcus and other infections like parasitic infections. These are all different types of different causes of chronic meningitis. And apart from these infective causes, there are certain non-infectious conditions which is also associated with chronic meningitis, and these may be neoplastic etiologies or certain other systemic illnesses like sarcoidosis, SLE, and other different disorders including Fabry's disease and Behçet's disease also. In up to 1/3 of cases, idiopathic non-infectious conditions can be observed. Certain drugs like IV, IgG, and non-steroidal anti-inflammatory drugs can also be a source of chronic meningitis. So you should think of these different non-infectious causes if you don't find any infectious etiology while having a patient who is suspected to have chronic meningitis or meningoencephalitis. So the approach or clinical approach is basically, first of all, to establish the time course of illness. What was the duration of illness? Initially started with which symptoms, and then progression of the disease, and how much time it has when your patient has first symptom. If your patient has symptoms and signs more than 4 weeks to 6 weeks, and it is progressing, then you should think of chronic etiologies. Along with that, a thorough historical account of neurological symptoms and a review of systems must be performed, because as we know, there are certain diseases systemic in which there is involvement of the meninges and brain parenchyma along with systemic multiple system involvement also. So the diagnostic clues may be identified on social history. For example, your patient has history which is suggestive of sexually transmitted diseases, And epidemiological history is also very important. Recent history of travel and certain occupations and hobbies are also involved, or given clues to different pathogens or different type of etiologies. Drug history, as we have already discussed, certain drugs like common drugs are NSAIDs and IV immunoglobulins, which we use commonly in our patient. These are also found to have they can cause aseptic meningitis. So apart from all these things, immune status and immunization history is also very important. In those patients who are immunocompromised, or in those children who has not properly immunized, they are supposed to have chances to develop these chronic type of meningoencephalitis. Certain toxins, animals, and sick contacts. For example, patients who has, for example, they are having contacts which are having certain chronic infections, like for example pulmonary tuberculosis. So in families, and they are treated or not treated, there is chances of development of as we know, tuberculosis is a contagious disease, so family members can also be affected by contacts. Raw and unpasteurized milk and raw meat consumption is also associated with certain, for example, in cases of listeria and other brucellosis. So these can be a source of infection. So in chronic meningitis, it is essential to perform careful general, systemic, and neurological examinations, looking especially for the following. For example, lymphadenopathy, papilledema, raised meningism, involvement of the meninges, and cranial palsies, and other focal neurological signs. These are very important, and they can give you clue towards your diagnosis. These are certain systemic. This is a table which is showing certain disorders which has systemic diagnostic clue in chronic meningitis. There are a list of conditions. For example, cryptococcosis, in which patient neurological presentation is headache and fever in almost 75% of cases, and nausea and vomiting in 50% of the cases, with altered mental status in almost 50% of the cases. Systemic involvement could be of lungs and other multi-organ involvement. And in neuroimaging, you can find hydrocephalus, cerebral edema, leptomeningeal enhancement, and cryptocomas. And this is all about cryptococcosis with systemic involvement with neurological presentation. And it's a possibility that your patient has chronic meningitis because of cryptococcosis. These are other causes also. Now, going into details of tuberculosis, like neurological manifestations, again, we all know fever, low-grade fever with headache, vomiting, meningeal signs, focal deficits, visual impairment, and cranial palsies, with systemic symptoms like, as we discussed, anorexia, fatigue, weight loss, fever, myalgia, and pulmonary symptoms. So in these patients, if you see radiology of those patients, MRI or CT scan, there with contrast, enhancement of the basilar meninges, you can find thick exudates, obstructive hydrocephalus, and tuberculomas with periventricular infarct. So these can be found in patients who has tuberculosis, and they present with these symptoms and come with MRI or CT scan with these findings. As again, syphilis and borreliosis can also cause chronic meningitis. Now, going into the details of tuberculous meningitis, it's a very common disorder, and in underdeveloped countries with higher overall incidence of tuberculosis, TB meningitis is more of a pediatric disease, and whereas in developed countries, it's with lower incidence of tuberculosis, TB meningitis is more of an adult disease. The demography of CNS tuberculosis is a major cause of morbidity and mortality, and especially in low and middle income countries. And there are certain risk factors which are associated with CNS tuberculosis apart from having tuberculosis. For example, in patients, malnourished patient, there is chances to develop tuberculosis. In HIV infected patient, it has been seen that 50% there is chances to develop extrapulmonary tuberculosis, and also risk of acquiring tuberculosis and even progression of the latent pulmonary tuberculosis. In IV drug abusers, in alcoholics, in patients who are on chronic steroid or immunosuppressive therapies, in patients who are on chronic hemodialysis and chronic renal failure disorders, they are more prone to develop CNS tuberculosis. Solid organ transplantation is also one of the risk factors for acquiring CNS tuberculosis, as far as carcinoma of the head and neck is also involved. So how it present? What are the clinical presentation? CNS tuberculosis manifests itself primarily as a tuberculous meningitis, TBM, in young, and less commonly as tubercular encephalitis, intracranial tuberculomas, or intraspinal tuberculomas, and sometimes tuberculous brain abscesses, rarely. So TB meningitis is very difficult to diagnose, and a high index of suspicion is needed to make an early diagnosis. Now, the pathogenesis, how tuberculous meningitis develop. So this tuberculous meningitis develops in 2 steps. First is when Mycobacterium tuberculosis bacilli enter the host by droplet or inhalation, there is a localized infection escalates within the lungs. In the lungs, there is a local infection with symptoms, which disseminate to the regional lymph nodes, and in persons who develop TBM, bacilli seed to the meninges of brain parenchyma, again by different routes, resulting here is a hematogenous route, resulting in the formation of a small subpial or subependymal foci of caseous lesions, which are termed as rich foci. So the second step in the development of pathogenesis of tuberculous meningitis is an increase in the size of these rich foci until it ruptures into the subarachnoid space. If it ruptures into the subarachnoid space, there is involvement of the subarachnoid space, and through which patient gain access to different meninges also. These tubercle rupturing into the subarachnoid space, these can cause meningitis. So after the release of tubercle bacilli, what will happen? What happened after the release of tubercle bacilli from granulomatous regions into the subarachnoid space? What is happening? There is a continuous process of inflammation. A dense gelatinous exudate forms, which most florid in the cisterns and surrounds the spinal cord. And this exudate envelops arteries and cranial nerves, which is creating a bottleneck in the flow of CSF. There is obstruction in the flow of CSF leading to hydrocephalus. This is a complication. So the exudate contains erythrocyte. These exudates, which form here because of inflammation and a lot of proteinaceous material, these exudates contains erythrocyte, neutrophils, macrophages, followed by lymphocytes in more mature cases. So the most serious consequence of tuberculous meningitis, however, is the development of vasculitis. So later on, what will happen after hydrocephalus and after obstruction, raised ICP, these serious consequence of TBM would be the development of vasculitis, the vessels of circle of Willis, vertebrobasilar system, and perforating branches of middle cerebral artery, in the form of ischemia and infarction in the distribution of these vessels. So this is a gross anatomy of the brain, which is showing white gelatinous material and on the basilar part of the leptomeninges. And this is the CT scan of the brain, axial view with the contrast study, in which there is a marked enhancement in the basal cisterns. This is basal cisterns, and this is white, and this is marked enhancement of the basal cistern and meninges with dilatation of the ventricles. Temporal horns of the greater ventricle, fourth ventricle, third ventricle, these are all dilated. Now this patient is developing TBM with hydrocephalus. Now, another manifestation of severe CNS tuberculosis is tuberculoma. Please, students, please type your questions in chat box. So in the end of the lecture, I will discuss, or I will give your answers to your questions. I will try to give answers of your questions. So after TBM, another type of presentation of CNS tuberculosis is tuberculomas. These tuberculomas are thought to arise when tubercles in the brain parenchyma. As we know, there are certain rich foci which are known as tubercles, which will found in subpile, initially in the subpile spaces, and later on it may enlarge in the brain parenchyma without rupturing into the subarachnoid space. As such, they often occur in the absence of TBM. So it's not necessary that if a patient has CNS tuberculoma, they also have TBM. They can present simple as a space occupying lesion. And they can be, tuberculomas can be solitary to multiple in number. And these tuberculomas of the brain show a typical, what they show a typical granulomatous reaction, which consists of epithelioid cells and giant cells, which mixed with predominantly lymphocytes around a central area of caseating necrosis, but no pus. So in tuberculomas, these are the space occupying lesions in which there is a lot of epithelioid cells, giant cells, and especially lymphocytes around a central area of caseating necrosis, but there is no pus. So this is the coronal section of the MRI brain, and this is the axial view of the MRI brain showing tuberculoma. This is single solitary tuberculoma, space occupying lesion with surrounding lot of edema. And these are multiple tuberculomas, especially in the brain stem, and this is left temporal lobe, and this is cerebellum, bilateral cerebellar hemispheres. So the third manifestation is tuberculous brain abscesses, which is a rare manifestation of CNS tuberculosis. So tuberculous brain abscesses develops either from parenchymal tubercular granuloma or via the spread of tuberculous foci from the meninges. And basically this is characterized by how they looks like. These are basically encapsulated collection of pus with containing viable bacilli without evidence of classic tubercular granuloma. So these are basically abscesses which have pus in it, but there is no evidence of granulomas in tuberculous brain abscesses, and they should be distinguished from granuloma with central caseation and liquefaction. So and they can be these brain abscesses or tuberculous brain abscesses, they can be solitary or multiple. And if we differentiate it with pyogenic brain abscesses grossly and radiographically, so tuberculous brain abscess has a much thicker abscess wall as compared to pyogenic brain abscesses. And this is the MRI sequences of tuberculous brain abscesses, and again it is there is a classical tuberculoma, solitary tuberculoma, a lot of fluid around it, edema around it. Now, clinical presentation again of these brain abscesses are fever, headache, vomiting, knuckle rigidity, certain cranial nerve palsies, especially third cranial nerve palsy, because of raised ICP, visual abnormalities, again systemic problems like lethargy, malaise, weight loss, and symptoms of raised ICP like headache, persistent headache, vomiting, photophobia, phonophobia, and cranial nerve palsies. Now, how we investigate these cases? in which we suspect that your patient has chronic meningitis because of tuberculosis. Again, brain imaging is gold standard, and triad of hydrocephalus, meningeal enhancement, and supratentorial enhancement, they will give clue along with history and clinical examination. Again, CSF with AFB smear and staining, and polymerase chain reaction for Mycobacterium tuberculosis, cultures for acid fast bacilli, and they can be positive, and they are clue for or help in the diagnosis of chronic tuberculous meningitis or tuberculosis. ESR can be raised, and XHS may show certain other findings which will show that your patient might have tuberculosis, miliary tuberculosis, or previous latent tuberculosis, or previous tuberculosis are evidences in XHS. So the typical CSF finding in CNS infections in as we are discussing tuberculous infection, so the opening pressure is very high or high, and the color of the CSF will be cloudy or yellow. And as compared to viral etiologies, cells are very much increased in cases of tuberculous meningitis, like about 25 to 500, and predominantly they are lymphocytes. And CSF plasma glucose is very low, less than 30% of, which is normally 66%. And let's about the discuss the protein content, very high or high, about 1 to 5 grams per liter. And this is the typical picture of CNS tuberculosis. Again, treatment options, we have antimicrobial therapy. Start as soon as there is suspicion for tuberculous meningitis, because if you will not treat the earlier, then there is chances of development of complications, even morbidity, and severe morbidity and mortality also. There are same guidelines as those for pulmonary tuberculosis. You should start with intensive phase 4 drug regime of isoniazid, rifampicin, pizadin, and ethambutol, or streptomycin for 2 months, followed by continuation phase, in which you can continue isoniazid and rifampicin for another 7 to 10 months. According to the response of your patient, you can increase your dose regimen up to 1 year to 2 years. So, and along with the anti-tuberculosis therapy, you should start adjunctive therapy, including glucocorticoids, and they are basically indicated in cases of if there is elevated opening pressure on lumbar puncture and there is a CT evidence of cerebral edema. If your patient's worsening clinical signs after starting ATT, because of increase, if patient has increased basilar enhancement or moderate to advancing hydrocephalus on CT head, you should start corticosteroids. And corticosteroids dosing is almost dexamethasone 12 milligram per day in 3 divided doses for 2 to 3 weeks, followed by a slow taper in next 2 to 3 weeks. If still raised ICPs still persist and hydrocephalus is again is a problem, then there is an option of VP shunting. What are now, as we know, it's a chronic process, and it's very difficult to treat, and also it's very difficult to diagnose. Also, you should have high clinical suspicion index of clinical suspicion. So, certain patients develop complications of CNS tuberculosis, even they started on treatment, or if they are not started on treatment, they have there are chances of mental retardation, and they have certain deficits and persistent cranial nerve palsies. They may develop blindness and deafness because of involvement of these areas, and these patients may develop epileptic focus, and later on they have symptomatic epilepsies. Because of the involvement of ischemia, blood vessels, and for example, middle cerebral artery involvement, patient might have developed MCA terati infarcts, and which later on persist as a hemiplegia or paraplegia, or patient might have paraplegia also. Even interventions, ventricular pylorient, patient may have hydrocephalus, recurrent hydrocephalus. So you should, if your patient is on treatment and still they may develop drowsiness or progressive drowsiness or other symptoms, you should scan, you should think of complications also. Patient might develop CIADH and persistent hyponatremia, and again tuberculoma. Now, second most common type of chronic infections are fungal infections. These infections are being increasingly diagnosed. There are two main factors contribute to this steady increase of fungal infections because of the widespread use of antibacterial agents, and also rapid increase in the number of immunocompromised populations. These are two main factors. And the fungal infections of CNS almost account for a significant proportion of opportunistic infections in patients with HIV. How it transmits? So the most of fungi are aerosolized and inhaled and initiate a primary pulmonary infection, which is usually self-limited. And again, transmission by hematogenous spread, they may follow the initial infection with subsequent involvement of CNS, and then the precipitating factor may be immunocompromised state, or patient has certain type of disorders like HIV. So the local extension from paranasal sinus is ear and orbit, and rarely trauma also provide the route to intracranial spread, for example, in cases of mucormycosis. So these are certain clinical syndromes which is related to fungal infections. It can present as meningitis, acute or chronic, rhinocerebral syndromes, intracranial mass lesions, and stroke syndromes. Fungal meningitis, basically meningitis or encephalitis, can be presenting clinical syndrome with most of the yeast like Cryptococcus, Blastomyces, and certain other Histoplasma and Candida. And because they have access to microcirculation from which they seed the subarachnoid space. So these are causes of fungal meningitis also. But the meningitis is the predominant presenting clinical syndrome of cryptococcal infections. And in about 40% of patients, it may be the initial manifestation of HIV infection. So one should think, if your patient present with chronic meningitis, and you are thinking of cryptococcal infections, then you should search for HIV infections also. So the fungal meningitis tends to be a subacute or chronic process. However, it may be just as lethal as bacterial meningitis if untreated. So it presents initially as your patient has altered mental status and recurrent seizures. These fungi can also produce meningeal vasculitis with vessel thrombosis and localized brain infarctions. So patient can present with certain other symptoms also. And patient might develop hydrocephalus and elevated intracranial pressure and complications after developing chronic fungal meningitis. So the cryptococcus, this is the MRI brain axial view and coronal images. These are basically showing certain cryptococci bilaterally in the basal ganglia and thalamus, and these are basically can cause meningitis with the involvement of meninges, meningoencephalitis because of the involvement of parenchyma, and also as a space occupying lesions. Another very devastating illness, which can be cause of chronic meningitis, is rhinocerebral syndrome, and these basically is form the most frequent presenting clinical syndrome in mucormycosis. This is the type of fungus which is mainly is most of the time associated with patient who is having diabetes mellitus. The clinical again manifestations of these form of rhinocerebral syndromes, basically patient starts having fungal sinusitis, and they will rapidly progress to involve neighboring tissues like orbit, eye, optic nerves, and extend to the brain also. And then later on, seizures and altered mental status and coma, even coma. So face patient may develop facial edema, lot of pain in that area, necrotic debris, involvement of the eye orbit. Because of that, patient has developed a loss of vision, and also black discharges along the nasal cavity, angle of eye, and proptosis. These are basically features of rhinocerebral type of fungal infection, mucormycotic infections. In this type of fungal infection, there is more chances to, or very frequent chances to have to develop angio invasion. Microvessels can be invaded by these infections. So there is lot of hemorrhages and necrosis. This is the MRI, and basically this is hypo and hyperintense signals in the area of ethmoid sinus, nasal sinuses, and also medullary sinusitis. This lady is having proptosis, lot of chemosis, and this redness and signs of inflammation. This is the heart phase in which the patient is having nasal discharges and lot of necrotic debris here with angio invasion, and also there is this is the area of hard palate and blackening of the hard palate. This is the pathognomic sign, clinical sign, which we can see in cases of mucormycosis. How to investigate these cases? Again, CSF-DR with fungal staining. Special staining is known as India ink preparations, and again cryptococcal antigens to the evidence of infections. Manometry of CSF is also very, CSF opening pressure is very high, so you should see the pressures also. And again, imaging, MRI brain and CT brain, in which you may find hydrocephalus or invasive fungal sinusitis. There may be evidence of invasive fungal sinusitis or involvement of the brain chyma, especially temporal lobe. Again, biopsy is helpful. So you should involve neurosurgeon as well as ENT surgeons for tissue or to diagnose on the basis of tissue biopsy. So typical finding is chronic fungal CNS infection would be high or very opening, CSF pressure with clear or cloudy appearance and almost 1,000 normal or high cells, predominantly lymphocytes, and CSF plasma glucose may be normal or low with normal or high proteins in a range of almost 0.2 to 5 grams per liter. So again, the management plan of these chronic infections, fungal infections, again, and we have antifungals, the popular antifungal which can cover almost all of the funguses, including mucormycosis and cryptococcal infections. So you can start with amphotericin. Other options are flucytosine, ketoconazole, fluconazole, and these are other antifungal drugs. So the usual regime is IV amphotericin B with flucytosine for 6 weeks, followed by fluconazole for 10 weeks, or indefinitely in immunocompromised or immunosuppressed patients. Multiple lumbar punctures for raised ICP or VP shunting for chronic hydrocephalus. Last but not the least is surgical debridement for invasive sinusitis. Now we have discussed tuberculous brain abscesses. Another type of brain abscesses are pyogenic brain abscesses. These are basically certain abscesses which can present as chronic disease, and it's categorized in the chronic brain infections, focal brain infections. So the sources again from where they arise, pathogen arises. 50%, almost 50% is through local sources, like for example, otitis media after having otitis media, sinusitis, and dental infections. In almost 25% of the cases, there might be a hematogenous spread, and in adults, the common areas are lung abscesses, bronchiectasis, and empyema. And in children, cyanotic congenital heart disease is the predominant cause in almost 4 to 7% of the cases. And bacterial endocarditis is also one of the cause of hematogenous spread of brain abscesses. While 10% of the cases has source after trauma or surgery. So the brain abscesses microbiology, as far as microbiology is concerned, there are certain pathogens which are most frequent, is almost 33 to 50% isolated organism is Streptococcus. And if multiple organisms are involved, almost 80 to 90% of cases, and these may include anaerobes also. When secondary to frontoethmoidal sinus, if your patient have frontoethmoidal sinusitis, the possible etiology or causes Streptococcus miliary or Streptococcus angiosus. When from otitis media, mastoiditis, or lungs, then multiple organisms including anaerobic or streptococci and bacteroids and enterobacteria like Proteus. They are possible etiologies. In cases of post-traumatic abscesses, there are chances that Staph aureus will be a main pathogen along with enterobacteriation. So the brain abscesses, again, clinical presentation symptoms are non-specific for abscesses and are normally due to increased intracranial pressure, mass effect, and depends on the area involved. Again, headache is almost in 75% of the cases. Patient present with headache and then fever and then altered level of consciousness in almost 50% of the cases, along with nausea, vomiting, or lethargy. And occasionally, patient might present with seizures. The symptoms progressively, slowly over days to weeks. So duration of illness is very serious, and it prolongs over days to even weeks. According to pathology, location, if we will see the location, mostly brain abscesses are involve temporal area, and then later on frontal, and least likely other lobes. In 10% of the cases, more than 10% of they are multiple. There are certain stages on the basis of histological findings of brain abscesses. It can be an early cerebritis, and that is poorly demarcated from surrounding brain. Then as the day passes on, patient develop late cerebritis, in which there is the involvement of the reticular matrix, collagen precursors, and development of necrotic center. Then in third stage, early capsular formation, there is a new vascularization along with necrotic center and developing capsule. In the late stage, late capsular formation stage, there is a lot of collagen capsule, necrotic center, gliosis, and surrounding capsule. Excuse me. This is the MRI brain gross picture. This is area of the early abscess or cerebritis, poorly localized from the brain parenchyma, and area of discoloration and softening. This is softening and discolored and poorly localized area. This is the early cerebritis. Later cerebritis means increasing necrosis of center with beginning of capsule formation. Increase necrotic center with capsular formation. You can localize this now from surrounding, differentiate it from surrounding brain parenchyma now. Mature abscess, late stage, dense fibro gliotic capsule, and this is a wall, capsular wall, and purulent center. The CT scan of the brain showing solitary brain abscess here, ring enhancing lesion. Again, in lab findings, you may find increased erythrocyte sedimentation rate and increased total leukocyte count, and blood cultures rarely helpful. Imaging of the brain again will be helpful in the diagnosis of brain abscess. So the initial management of brain abscess, blood cultures, you have to send blood cultures, although they are rarely helpful. Lumbar puncture role is dubious because of risk of transtentorial herniation. And so CSF is typically abnormal, but cultures are usually negative. So you should start initiate antibiotic therapy, preferably after biopsy specimen if obtained, and regardless of which management mode is chosen. Okay. So the brain abscess antibiotics, if you know pathogen is unknown. If you don't know pathogen or Staph aureus is suspected, you should start with vancomycin in adults 1 gram 12 hourly, along with third generation cephalosporin and either metronidazole, chloramphenicol, or for post-traumatic abscesses, you can use rifampicin. So this is a regimen you have to follow. Medical therapy alone is more successful if we have other options also. If medical therapy fail, then you can opt for surgical options. But if the treatment is begun before, medical therapy is more successful if you treat the patient before complete encapsulation earlier. The lesion, if lesion is 0.8 to 2.5 centimeters diameter or less, or typical cutoff is of 3 centimeters, then it might be possible that your medical treatment will be more successful. And if the duration of symptom is less than 2 weeks and the patient should show improvement in the first 2 weeks of treatment, you can predict that your medical treatment will be successful. In the surgical treatment options, what are the indications? When you go for or opt for surgical treatment, if there is significant mass effect exerted by those lesions and causing a lot of problems, then proximity to ventricle. Why? If it is proximal to the ventricle and there is a chances to rupture in the ventricles, and when there is a possibility of development of ventriculitis and spread of infection, pus. So you can offer surgical treatment. Then poor neurological condition. Apart, instead of you are giving antibiotics, medical treatment, appropriate medical treatment, but patient neurological condition is deteriorating. So that is also one of the indications. In patients undergoing medical treatment, when you have to intervene, if there is neurological deterioration, again, anatomical progression of abscess towards ventricles, or after 2 weeks of therapy if abscess is enlarged. So also consider there is no decrease in abscess size for almost 4 weeks of treatment. So if your patient in the beginning have significant mass effect exerted by lesion, or proximity to ventricle, or poor neurological condition, so you can opt for surgical treatment. And in patient even on medical treatment, intervention needed if there is neurological deterioration, if progression of abscess towards ventricles. After 2 weeks of treatment therapy, there is no regression of the size of the abscess, or if there is no decrease in abscess size by 4 weeks of treatment. So you should consider surgical therapies. So this is all about today's lecture. So if you have any question, please write it down in chat box. Otherwise, we will conclude. Any questions? So we have only 19. I think one of 19 is me and my coordinator. So we have only 17 students here. I think all of you understood what I have taught you in this lecture. But if you have any query or any problem, you can ask me, or you can type here in chat box. I'll answer you. Otherwise, you can contact me, my office in Civil Hospital, Karachi, Neurology. Thank you for your patience, and Allah Hafiz.